what I wanted to let you know that, yes, I'm Stuart Schlossman, president and founder of MS Views and News. So I'm just going to fill you in. So firstly, this is a Compass to Care Rural America program. We call it Compass to Care Rural America and beyond. Okay, and this event is sponsored by Genentech and Bristol-Myers Squibb. All right, and we got to give them a virtual round of applause. All right, so going along a little bit further now with today's program. So again, it's a Compass to Care Rural America and Beyond program. Dr. Aburashed is here to speak with you about, he's going to speak a little bit about what is MS. He's going to talk about the different types of MS. He's going to do a little bit on symptom management. He's going to speak about access to care, all right, and specialists that are needed. He'll also bring up something maybe on MS treatment options of what's going on today. And we're going to get started. So Dr. Aburashed, he's with the memorial, right, in Owosso. Did I say that right? Or Owosso? Where are you?
Owosso, Michigan.
Owosso, there we go. The W's before the S's. I got it. Okay, great. So anyway, take it away. You're going to have 35 minutes to talk, and then we'll do like another 35 minutes of Q&A after your 35 minutes of talk, okay? You good?
Sure. So I'm good.
Great.
Thanks, Stu.
Take it away.
Thank you, everybody.
Thank you.
Thank you, Stu, for the introduction, and thank you, everybody, for having me. I appreciate you guys giving me a little bit of your evening today. I apologize. I had a lot of technical issues for whatever reason. We couldn't get the webcam working, but now you see me, and welcome to my office in my home. So I kind of wanted to structure this in a pretty loose fashion, but I really wanted to kind of begin at the ground level of multiple sclerosis and maybe help you understand a little bit about the physiology of MS, and then we'll kind of build upon that as we go. Just as an introduction of who I am, so I am a board-certified neurologist and a neuroimmunologist who specializes in multiple sclerosis. I'm the chair of neurology at the Memorial Institute for Neurosciences and Multiple Sclerosis. So we are one of the few comprehensive MS centers in the country. At our center, we take care of approximately 2,300 MS patients now between me and and two other neuroimmunologists as well. But we also have 14 neurologists as a whole who specialize in every subspecialty of neurology. We're extraordinarily active in research, so from phase 1 trials, phase 1, 2, and 3 primarily. And then my personal research is based in blood-based biotesting, so biomarker testing for multiple sclerosis. And I think many of you, or some of you who have been on, are familiar with some of the work that we've been working on really hard, and it's kind of exciting, and we're at a stage right now where we're using artificial intelligence to analyze data on MS patients, and we're looking at multiple data sets, including blood tests, the MRI, the atrophy on the MRI, their walking, their hand speed, amongst other tests, and we're letting an artificial intelligence machine really build a structure to give us better prediction for individual care. So my focus is really individual care. We won't get into that too much today, but with that, I'll begin. So what is this disease of multiple sclerosis? Many of you have been to lectures and have heard this a million different ways. I do have a way that I like to explain MS to patients that I think is beneficial and maybe can help you understand it. So let's imagine for a second that I cut my arm here with a knife, and imagine that I put some dirt into that wound, right? That wound's going to get infected, okay? So let's talk about what happens inside the body when the body is given an issue like this. So you have this infection sitting in your arm. In our blood right now, we have cells that are moving around our blood, and these cells, their job is primarily surveillance of the entire body. So they will peek in on the heart, peek in on the liver, peek in on the kidney, and they will look really for anything that is not supposed to be there, any toxin, any bacteria, any cell that's growing wrong. And their job is really to be traffic cops, essentially, for the body. Well, those traffic cops, those cells, which are called the innate immune system, make their way to the arm here. And when they see that bacteria in the arm, they focus on that bacteria, and they look at it and they say, that's not supposed to be there. That should not be on Stu's arm, okay? They then approach that bacteria, get a closer look at it, and say, okay, I'm going to destroy this bacteria. So these security guards, so to speak, try to arrest the bacteria. They try to control the infection on their own. And 9 times out of 10, that part of the immune system, the security guards that are surveilling your blood at all times, can take care of the vast majority of infections and things like that. Well, 1 time out of 10, they're fighting off this infection, and the infection is pretty aggressive. So it's a bug that has a lot of, complex DNA, and it has the ability to kind of replicate quickly, and now it's fighting back pretty aggressively. So now the arm is getting really red and really inflamed, and maybe you have a fever now, okay? So the infection has worsened, it's deepened, okay? Well, the security guards are staring at that infection, trying to fight it off, and realizing pretty rapidly that, oh no, this is a problem. Like, mayday, mayday, we need help, okay? So what they do is they contact the second part of the immune system, which is primarily made up of B cells and T cells. Now, these cells are our Navy SEALs. These are the best fighters that we have in the immune system. And they only get activated when we really need them. So we don't use B and T cells every single minute of every single day. So the B and T cells are hanging out, relaxing, having a cup of coffee, doing whatever it is they do, okay? Primarily in the lymph nodes. And they get a phone call that says, mayday, mayday, Stu's left arm has got a bad infection, okay? The B cells and T cells wake up, they grab a gun, they jump in the blood, they swim to the arm, and they destroy that bacteria using all of their beautiful advanced technology, okay? So the B cells and the T cells are kind of our saviors, so to speak, and they destroy that bacteria, and then they do something very interesting. They take a picture of the bacteria, and they put that picture in their back pocket, and the reason they do that is so that in the future, if you're ever approached with a similar bug, they immediately know this is a tough little guy, we need to come out right away. We don't want this to get as bad as it got this time. Does that make sense? So picture that scenario in your head, okay? That would be normal immunity. That would be the process of the body fighting off infection. Well, what happens in autoimmune diseases like multiple sclerosis is the surveillance cells are doing their normal surveillance, like I mentioned. They're swimming through the heart, through the lungs, through the kidney, through the liver. They're looking for everything that shouldn't be there, and they come upon the outside of the brain tissue and the spinal cord tissue. And they look inside just to make sure things are okay, just to kind of take a peek. And when they look inside, they see a protein on the covering of something called myelin, which you're all very familiar with, okay? So they see a protein on the covering of the myelin, and all of a sudden, they get a little bit hazy, and they say, is that part of the body? Should that be there? Should it not be there? And they kind of hem and haw and try to figure that out. And then eventually they say, that's foreign. That is a foreign invader. And they make their way into the brain, and they begin to chew away at that protein. Well, the protein's not going away because it never was supposed to in the first place, right? The protein was part of the body. And this is an error on the part of the innate immune system. Well, as they're chewing away, they're realizing we're not killing this like we're supposed to. So what do they naturally do when they can't kill something? They contact the lymphocytes, the B and T cells, the Navy SEALs. So they call the Navy SEALs and they say, hey guys, we've got a bad little bug here. Let's come in here and help me on the left side of the brain. And the Navy SEALs do what they're supposed to do. When they're told to attack this enemy, they make their way into the brain. They attack the covering of the myelin. They cause damage. And then they take a picture of that protein. And now you've got multiple sclerosis. Okay? So now your body has made an error and starts to believe that the myelin or the protein that's covering your brain tissue and your spinal cord tissue should not be there, okay? Well, the Navy SEALs take that picture, they finish the attack, and they go back to sleep for a long time. In some patients, they go to sleep for 10 years. In some patients for 1 month. In some patients for 4 months. Every single case is very different. Invariably, what will happen is they will go back to sleep, so you'll have an attack or a relapse, and you will develop a symptom, and you will start to heal from that symptom a little bit. And then at some point in time, they come back out and they attack again. And that is considered relapsing multiple sclerosis. So when you talk about the types of multiple sclerosis, the most common type is something called relapsing multiple sclerosis. And what that basically means is a series of attacks followed by a period of kind of quiet, and then an attack followed by quiet, and so on and so forth, okay? That is differentiated from a different type of multiple sclerosis called primary progressive. Primary progressive multiple sclerosis is much rarer, thankfully. We only see that in about 10% of cases, and that is when the attack begins and it doesn't stop. It's relentless, and you just see a slow decline over time. So you develop an attack, your right foot stops working, all of a sudden your right leg stops working, all of a sudden your right arm stops working, and it just gets worse and worse and worse, okay? That's a different mechanism, and that's very rare. Another type of multiple sclerosis you should be familiar with is secondary progressive multiple sclerosis. And what that means is it begins with attacks, Navy SEALs attacking, B and T cells attacking, going back to sleep, attacking, going back to sleep, attacking, going back to sleep. But then, over a number of years, they no longer are attacking. What's starting to happen now is the brain is starting to shrink to a point that you're starting to see a slow progression of your symptoms. So it's not that you're having sudden new symptoms, it's just that that left leg that was really bad in 1994 and then got better and then started to get worse again in 98 and then got a little better with some therapy and then started to get worse again in 2002 and has considerably gotten worse over the next 5 to 10 to 15 years. That would be something that we consider secondary progressive disease. So when you think of the types of multiple sclerosis, the majority of you will be categorized as relapsing multiple sclerosis. Many of you will be categorized as secondary progressive multiple sclerosis, and some of you will be categorized as primary progressive. Now, here's the most important part of this part of our talk. Relapsing multiple sclerosis and secondary progressive multiple sclerosis are not binary. It's not 0 and 1. So you don't have relapsing MS and then suddenly you have secondary progressive and that's it. No, it is a continuum. So at all times when you develop that first attack, as the Navy SEALs leave, there are some cells that are left in the brain or in the spinal cord. And those are primarily cells called microglial cells. And these are like little whisperers. And they slowly degrade the brain underneath everything, okay? So you may not notice it for many years, but there's slow degradation of or atrophy of the brain that's occurring underneath all of this. So you have that attack that we see on the MRI, but then you have what's left over, these cells that are slowly degrading, and eventually you run out of backup brain to kind of protect you, and you start to notice more and more symptoms, okay? So when you talk about multiple sclerosis as a whole, every single patient will have a very different symptom complex to their multiple sclerosis. And the reason for that is pretty simple. It's all about the location. It's like real estate, right? So you have parts of the brain that are like Nebraska or Iowa, right? You got cornfields everywhere. And if anyone who's on from Nebraska or Iowa, I love you. I work in a cornfield, so I love cornfields. You've got land and land and land and land everywhere, okay? And if you take a chunk out of a cornfield, nobody might, the only person who notices is a farmer who farms that corn. Because when you're on the road, you can't see deep into the cornfield. You don't know that there's a little pocket that's missing. So the brain, if those attacks are in Nebraska or Iowa, you may never notice them. So you might have MS for several years and not have any symptoms because it occurred in a part of the brain that is not populated very densely with cells, okay? You have other parts of the brain that are like New York City, and New York City's got, Central Park and it's got, Times Square. And one thing to think about is if you destroy a road in New York City, it's not very easy to move traffic anymore. You can't just build a new road because you've got a skyscraper here and a skyscraper here. And if you kill that pathway, all of a sudden everything's got to go around 9 skyscrapers to get to point A to point B, okay? In Nebraska, however, if you take out a little piece of a cornfield or you take out a little road, you got plenty of room to the right and the left to just kind of rewire. Your brain will intelligently rewire that area of damage. So your symptoms are going to be based on the location of the attack. And that strictly is a byproduct of luck. There are some common areas that are affected. So the optic nerve or the eye is affected in about 20% of cases. And that's primarily because of a little bit of weakness in the saran wrap that's covering the brain, that protective barrier that covers the brain. And so many of you have had optic neuritis or vision loss in one eye at some point. Usually it's one of the first symptoms we see. Some of you have had double vision or diplopia. That's because that's similarly an area that oftentimes is attacked. Many of you will have numbness as a first symptom. My right side went numb for a period of weeks, to days. So your symptoms are your symptoms and yours alone, and they're very unique, and every single one of you is extraordinarily unique as it pertains to your MS. And for that reason, our approach to how we treat your multiple sclerosis is extraordinarily unique. So I will leverage that into the next part of this topic, which is treatment and how we approach MS. So when we look at what the immune system is doing as a whole, you don't have a weakened immune system when you have multiple sclerosis. You actually have overactive immunity. So your immune system is actually stronger than we want it to be. It's doing things we don't want it to do, okay? And so our goal in treatment is to bring it down towards that normal level. We want to either modulate it, so adjust a part of the immune system to bring it down with certain drugs, or we can suppress it, where we really shut it down significantly if you have a lot of attacks or bad multiple sclerosis, right? Or if we really want to knock it or nip it in the bud right away. So our entire goal in treatment is to start where you are and to bring you down to a more favorable area where we think we can maintain your immune system and prevent future attacks, and in a lot of cases try to heal the brain and get rid of some of those cells that are underlying and chewing up the brain very slowly, okay? So because of that, there's no such thing as the best treatment in multiple sclerosis. So a lot of patients ask me this, is what is the best treatment? And in a given day, I will give 5 to 6 different answers depending on how many patients I see, because every single case is different. In some cases, they have a little bit of a spark, and all I need is a water bottle to pour on that spark and everything's done. All right, they're going to be fine for the most part. In other cases, it's an entire forest fire, and I need to bring in the heavy hitting drugs, and I need to really suppress the immune system to quiet it down. So as a patient, you know, one of the questions that you want to ask is, in the scheme of multiple sclerosis, when you look at MS patients, how severe is my MS? How active is my multiple sclerosis? Those are questions that you want to ask when you're discussing treatment options, because you don't want to just take aggressive treatment for the sake of aggressive treatment, and you also don't want to be using a water bottle for a forest fire, because that's not going to help us either. And so the art of practicing multiple sclerosis and the art of what we do is, you know, taking a combination of our experience, your MRIs, our testing, and really assessing what is the right degree of water that I need to pour on this fire to quiet this down completely, okay? So that would be what we call disease-modifying therapy. So that's one box of treatment, is to think about MS and your MS as I'm going to be on a drug that is modifying or suppressing my immune system. And that is the goal of that treatment, okay? The other part is something called symptomatic care. So there's 2 components to how we approach an MS patient. The first and most important is disease-modifying therapy. What is the right drug for your particular case? Let's get you on that as quickly as we can. Let's fight your insurance company for 9 days and figure out what the heck's going on. And we're gonna put you on this drug and hope to God we've got you on the right one. And if not, we're gonna adjust rapidly and not kind of sit around and watch you get worse and wallow, okay? Then you have your symptoms. So multiple sclerosis patients commonly have a very common symptom complex. So I'm going to say several symptoms right now that everyone who's sitting in front of a computer is going to nod their head and say, oh my God, oh I got that, oh I got that. And that's because we hear it over and over again. We are very familiar with what this disease does. So one of the most common symptoms that we hear about is something called fatigue, which we all know about. Fatigue in multiple sclerosis is different than I didn't sleep enough. And this is something that caregivers, I think, should hear very clearly. Not sleeping enough makes you tired. It makes you groggy. It makes you a little bit annoyed, easily irritable, less patient, okay? So that's one. Fatigue in MS is where you sleep 7 or 8 hours and you wake up and you might feel okay. Not perfect, but okay. And you get your coffee and you get moving. Suddenly, a certain time comes and you just run into a wall. And I mean a wall. And it knocks you down on your butt and you're kind of done for the day in a lot of cases. And everyone's got, this ranges from mild to severe, depending on someone's MS. And so from a fatigue standpoint, we look at symptomatic care. So we have several options that are not perfect by any stretch of the imagination, but they help. These are drugs like Provigil and Nuvigil or an Adderall and Ritalin and so on and so forth. So stimulants, things that are going to try to perk you up, get you some energy, and kind of get you through your day and get you through your life. Number 2 is depression. So the vast majority of MS patients will at some point experience a true depression from their multiple sclerosis. And this is both a combination of dealing with a chronic illness, which is really a challenge for people. It's very hard mentally to wrap your head around a chronic illness, especially one that's unpredictable because there's a ton of anxiety. And as an MS patient, I can imagine, and I've talked to many patients about this, and I'm pretty familiar with it, you know, every day you wake up without a relapse, there's maybe you get used to that because you don't have more relapses than living, but there's a slight sigh of relief that you can move that leg and you still have the same degree of numbness, or it hasn't worsened, or the vision hasn't gone away worse or gotten worse. And so there's an anxiety that builds, and that builds a pressure in an MS patient. And that pressure kind of always, you know, conglomerates into depression. So we very often will have patients on a drug for stimulation, for fatigue, a drug for depression, okay? The third one that can occur later on as time goes on and with enough time behind you with MS is cognitive change. Really a struggle with the ability to think, a struggle with the ability to process complex issues, to multitask like you used to. So the story we hear all the time, daily, is I'm just not as sharp as I was. I used to be so good, and I used to manage 10 things in the office, and now, my God, man, I'm so absent-minded and I'm making mistakes. And you start to get this kind of cognitive change, and that's really a challenging part of MS for many patients because we don't have great treatment for it. We try a variety of things sometimes, but invariably they're not fantastic. So we really, you know, the point with that one is our goal is to really not to try to prevent you from getting to that stage as much as we can by putting you on the right drug at the right time, by being aggressive when we should be aggressive, and so on and so forth. The fourth one is if you have severe enough damage, you might have something called spasticity, or a tightness in a limb, in an arm or a leg, where maybe your left arm was your first attack. It went weak and now it's back, all right? Doesn't feel perfect, but it's back. It's 80%, 90%. Well, over time, it can start to contract a little bit and feel just a smidge tighter. So when I'm seeing an MS patient and I move their arm like this, right versus left, I'm comparing how spastic are they? What side is weaker? What side is not weaker? What side is tighter? And oftentimes we'll use medications like baclofen for that, okay? So we can put you on something to kind of loosen that up. So remember, 2 boxes: medication for the immune system, which you should be on, and then medications for your symptoms that help you live your life in a way that is high quality. Because the goal of all of this is quality of life. When I see an MS patient, the first thing that I want you to understand is, by the nature of your disease, no longer is there a normal. You have a new normal. And the faster that's understood and the more accepting you are of that, the better we are going to be equipped to fight for that new normal. So some of the patients that I think struggle the most with multiple sclerosis are the ones that are constantly comparing to life pre-MS to their current life. Now that's okay in the beginning. You're justified in that. But over time, you have to at some point understand there is a new normal. And that new normal becomes our measuring post. And my goal is to keep you at that new normal at a minimum, and hopefully get you a little better in some cases. But the first goal is to prevent it from deteriorating, you know, prevent it from getting worse. And that really is you know, one of the things from a mental standpoint that I want patients to understand and wrap their heads around. If you're able to understand psychologically the complexities of a chronic illness, you will learn to live with it in a way that probably in some cases is a higher quality of life than many non-MS patients have. I know that sounds bizarre, but I have patients who live more full lives with MS than I do, you know, friends who live average lives that are really not doing anything because they've kind of taken for granted their limbs and their arms and their eyes and their so on and so forth. So you know, I don't mean to belittle that, but I also, you know, one of the things that I demand is you know, we got to buckle up. I mean, we got to tighten up, and we're going to boo-hoo for a bit, and then we're going to build, and that's it. We're going to allow this to take its course. We're going to let our mind wrap its head around it, and then we're just going to fight back. And so, you know, I always think of Rocky IV, you know, the movie with Sylvester Stallone, and when he's training in the mountains and so on and so forth. And you know, you might be paralyzed, and for you, training might be a 1-pound weight that you're just, or it might be a ball that you're just squeezing to maintain dexterity in that hand, okay? But the degree and the fervor to which you're training should be equivalent to Rocky training in the mountain. Because if you view this correctly, you understand 2 concepts. Concept 1 is life is hard in so many different ways. Some of us are challenged physically with diseases and disorders. Others are challenged mentally. Others are challenged financially. Others are challenged emotionally, and so on and so forth. But life is hard. And most human beings are not very comfortable. They're all pretty, we all get by, and there's different levels of happiness, but most human beings are in some type of struggle. And so once you accept that this is your struggle and understand that not everybody has it better than you, they might walk better than you, but they might have a catastrophe that you don't know about. And once you do that, I think it helps you, stop feeling sorry for yourself and kind of beginning the process of healing, which is what I want. The second component of this, and what I think is important, I had a long conversation today with a patient who really has bad MS, and she's pretty beat up, and she's in a wheelchair, and she's still on treatment. And today she said, I don't even know if I want to treat this anymore. And she said, I said, are you getting worse? And she said, well, look how bad I am. I'm not getting worse, but I've got only one arm that works. I've got another arm and two legs that don't, so on and so forth. And I said, one of the goals is for you as a patient, you look at how you feel right now. So you're in your body, and it's tough sometimes because you're struggling. One of the things for me as a clinician is I know the research that we're doing. So I know that we are currently working on 2 phase 2 remyelination trials, drugs to rebuild damaged myelin. And they're already in phase 2, which means they'll be in phase 3 within a year, which means phase 4 within 2 years, which means theoretically within 2.5, 3 years, we may have a drug that can rebuild myelin. And wouldn't I rather put you on that drug with the same disability that you have when you're in front of me today than allowing the disease to progress more and only being able, so imagine the drug gets you 20% more, right? Let's just assess that it gets you 20% back. Well, we want that 20% to be at the highest. We want you to start at the highest level possible, whether it's 1 arm, 2 arms, or four limbs. We want you to start at that highest level, and then we want to build on top of that, okay? So it's really, when you start thinking about your disorder or thinking about MS, I want you to think about it conceptually on the long scale. We are playing, this is a marathon that we are fighting. We will deal with the today. And so my patients who are on know that one of the things I always say is that macroscopically, I love how you look. From 10,000 feet, love it. Your MRI is stable, your exam is stable, you're not worsening. And then I say microscopically, we have several issues we have to deal with. One of them is your bladder is leaking. That's a problem. One of them is your left leg is hurting. That's a problem. One of them is your depression. That's a problem. And so you start to kind of understand that there's a macroscopic long-term component, and then the microscopic day-to-day that we want to work very hard at improving for you to get you to the highest quality of life that you can get to, okay? So when you talk about the disease, so we went through kind of what the disease is. We went through the types of the disease. We went through the treatment of the disease. We went through kind of the disease-modifying drugs, the ones that suppress the immune system and alter the immune system, and we went through some of the symptomatic care. And then we talked a little bit about the psychology of the disease. Now, one of the questions that I often get, especially in the current era, is because I have MS, am I at a higher risk to get COVID? And I get that question all the time. And so let me answer it in 2 parts for you. As a disease itself, if all you have is MS, then the risk of you getting COVID is equivalent to someone else. It's the risk of getting an infection, okay? Some of the medications that we use in MS are suppressing the immune system a little bit. And we have concerns about, should you get COVID, how will your body fight back? So 2 separate entities. Just because you have MS doesn't mean you are at an elevated risk to get COVID for the most part. But some of you are on treatments that are bringing the immune system down, and that gives us a little bit of pause, a little bit of concern about kind of how we approach this pandemic in its current state. The bigger disease than COVID right now for MS patients is, number 1, a lack of exercise, and number 2, depression because of isolation. With a disease like MS, you start out isolated. Your life begins isolated because you are one of 1 million people in the country who have the disease. So you're already a very small number. Out of 300 million, you're one of 1 million, right? So you already feel isolated at baseline, and now you're truly isolated. And so many patients that I'm talking to now, I had a woman today who got added onto my schedule for a phone call because we're doing all virtual visits. We just did a phone call. It wasn't even a WebEx. And I said, what's going on? They called, said you wanted to talk to me. Are you okay? Have you had a relapse? Anything worsening? What's going on? And she said, honestly, I'm just alone and I just wanted to talk. And she just wanted to talk for 10 minutes. And it's really eye-opening when you start to hear this story over and over again in our patients about the pandemic's effect on depression and isolation. And so what I would say to you is, to those of you who are on here, this is a huge first step. And it's a huge step to try to continue to live your life and to fulfill your life and to feel like you're moving forward with something and to learn something new. So I commend you on that immensely.
Thank you for doing all that. Can you please speak with people about how they can better effectively speak with their care provider?
Absolutely, yeah. So that's actually a huge issue that I think as a patient, so the first thing I'll tell you is this: you are your best advocate as a patient. And you as a patient are really the driver, not of your treatment, because your doctor is going to talk to you about what they want to use and so on and so forth, and they're going to educate you if they do it correctly. But you are the driver of the attention to detail of your case. And what I mean by that is not that your doctors don't care. I care immensely. I stay up and lose sleep all the time for my patients. But I have so many patients. And there's only one brain. And there's only one mind here. And so the reality is, when I treat you, even giving full empathy, full care, full compassion, there's just not enough hours in the day or minutes in the day to check every box. So as a patient, the first thing I would say is, if something is going on, you have to know you have a doctor that, if you make them aware of it, they will be reactive, okay? That they will actually acknowledge and figure out how to help you, how to get better. And none of us are perfect at this because, again, so many hours in the day. But you do, as a patient, want to be your own advocate and really have a rapport with your physician where it becomes like a family type thing. So you want to know that your doctor knows who you are. You want to know that they, so now I've been doing this for 15 years. I mean, the majority of my cases, just give me a name and I can tell you what drug they're on. Right? And that's just over years of getting to know them. If I've taken care of them for a while, I don't need my chart. I don't need anything in front of me. I can remember their first relapse. I can remember their attack. I can remember their MRI in my head. And so, but if they don't call me and tell me something's going on, I'm going to assume they're doing stable and doing fine. So number one, be your best advocate. Number two, you've got to do the homework to find the right clinician. You need the right doctor or PA or an NP or whatever it is you see. And there's two components to that. You want ability, so you want to make sure these are people who take care of MS at a high level. How many MS patients do you have? How long have you been doing it? Do you use all the treatments? Are you familiar with all the treatments? Do you stay up to date with all the treatments? So number one, ability, and number two is affability. Number two is affability, and that means the rapport that you have with them. If you are not comfortable with your physician, if there is a block in terms of comfort, it will hinder your MS care moving forward. If you don't like them and it's just someone you go to and there's no relationship, when something happens, it's going to be a concern. And then the third component is availability, right? And this is one that I struggle with because I'm stretched so thin, and it's something that I can constantly try to work on, constantly try to improve processes. And this is just, when you need to see them, can you get in? When you need to call. So I mean, this is my one weakness, is that part of it. And strictly because of just the sheer number of patients that need to come and be seen and so on and so forth, and the other things we have going on. However, the caveat to that is that when a patient calls, if they say, I need to talk to the doctor, 9 times out of 10, they will get me on the phone for the patient, no matter where I am in the world. I can be in Barcelona, I can be in Sweden, I can be in Texas, or I can be down in Florida visiting Stu. In his COVID soup. And so you want to find those, you want to measure those three things and figure out in your mind what % you want of each. So if someone's brilliant, but they're terrible to talk to, it's going to be okay for a minute, and then it's just going to fall apart, and you're going to find somebody else. And so you want to try to find that. And so as a patient, I would say researching, talking to other patients, doing things like this where you're seeing different clinicians from around the country. When you look at MS specialists as a whole, you're talking about, there's about 100 people in this country, doctors in this country, who prescribe about 70% of the MS treatment in America. So, us 100 are really the drivers of this disease and the ones that see this disease a lot. And so it's a very small number when you think about it. Stu?
Hi, I'm back. I'm sorry. Again, it takes a little bit to click, it takes a lot to click. All right, but anyway, thank you for all of that. All right, that was great. We're going to start Q&A in a moment. All right, that what I asked you to speak about was not Q&A, but I do want to thank you for being on here and for helping to educate this MS community, who is, for tonight's program, we have about 100 people online right now. And of course, there's going to be, it'll go onto our YouTube channel, and there'll be thousands more clicking in over the next couple of months. So I want to get started with some of these questions that we have. People want to know if you can tell us more about some of the MS medications, such as some of the newer ones like Kisimta and Mayzent.
Okay, sure. So when you think of MS medications, we primarily break them down into 3 boxes. Okay, so box 1 is injectable medication, or really needles. Box 2 is pills, and box 3 is infusions, or drugs that go through the IV. And within each of those boxes, you have a number of treatments. Okay, so the first batch of drugs was the injectable treatments that started in 1993, with beta-seron. And there's several variations on a class of drugs called interferons, and those are drugs that we still use in certain cases. Older drugs, we know their safety incredibly well. We have good access to those treatments, and so on and so forth. And then within the injectables, there is a new treatment that I'll talk about shortly. So injectables, and then you move into the pills. And with the pills, we really have what I would consider 3, or I guess 4 now, 4 main classes of pills. So one of them is something called the Fumarates. So there's 2 types of Fumarates, Tecfidera and Vumerity. There's a class called the S1P modulating drugs, and there are several of these, Mayzent being one of them, Zeposia being one of them, and then Gilenya being kind of the older one that we've had for about 10 years now. And then there's another drug called Aubagio, which uses a different mechanism entirely. And then there's another pill called Cladribine, which again uses a completely different mechanism. So when you start to think about this, I don't want to go into each one in detail, and I'll touch on the newer ones just to give you some education on them. But I want you to understand that within each of these, you might say, oh, I'm on a pill, but it could be a totally different pill than patient X, Y, or Z, because there's several pills that we use. And then we move into what we call the infusible drugs. And these are really 3 main drugs. So Ocrevus, Tysabri, and Lemtrada are the 3 main infusible drugs that we use. And they all have various pros and cons, and we use all of them in our clinic. So I have patients on every one of these drugs, depending on their MS specifically. Now, recently there was a drug called Kisimta that was approved by the FDA. This is a once-a-month injection, and it is a drug that targets B cells very similarly to one of the infusion drugs. And so, again, I don't want to get into a tit for tat in terms of what's the stream. Every one of these drugs has its own pro, and every one of these drugs has its own con. And so, part of our job, what I would typically do with a patient, is I would sit down, and my first job is to figure out, what exactly is your MS? What is your MS fingerprint? And then when I figure out what your fingerprint is, my job, and really where you need my ability in my advice and my expertise, is to give you options that are the right degree of strength for you. And then to discuss convenience and safety and accessibility and what works with your life. So today is a great example. I had a patient that I was going to put on a B cell drug. And there's 2 main B cell drugs. One of them is an infusion that you get twice a year, Ocrevus. One of them is an injection that you get once a month. This patient lives in the middle of nowhere, about 6 hours from anything. And so he specifically said, I can't come down twice a year for an infusion. Can I inject myself? because I can get him the drug and they can do it on their own. So that's an example of really a patient-driven treatment choice. Because to me, my job is I want this person on a strong enough drug to control their MS. And here are the drugs that I think are strong enough to do so. Which one works with your life? And so on and so forth. So as a patient, I think you want to be thinking dynamically about kind of, you know, I guess what I would say is this. If your doctor gives you a list of drugs and says, pick one, I don't think that's the right approach, because that's overwhelming, especially now. Now we've got so many treatments. It used to be 3 or 4 treatments. It was overwhelming then. Now we're up in the high teens, and it becomes a whole different animal altogether. So you want to have a conversation with your clinician, and I would ask several questions. One would be, why do you think this is the right drug for me? And let me explain it to you. And let me teach you scientifically why I want to treat you with this degree of strength or with this degree of mildness, for example, right? And then the second question is, what are the side effects, potential side effects? What's the potential safety ramifications of this? And then what is the convenience to my life? So convenience becomes a big issue. I take care of a basketball player. And for that patient, convenience is everything. For that patient, they travel, they're on the road, or they were pre-COVID, but they're on the road a lot. And so one of the things for them was taking out the injections when they were going through checkpoints, TSA and security, was becoming very tedious for them and becoming an embarrassment for them. They're doing great. They're doing fantastic. So for that patient, what they cared about wasn't safety, wasn't side effects. I mean, side effects matter if they occur, but what they cared about is, can I get a pill form so I can just throw this in my bag and move on with my day and not have to take out these injections every time I go through security, for example. And so you start to think about your case dynamically and so on and so forth. But I do want to reiterate, it's not the best drug in MS. That doesn't matter. It's the right drug in your case. That should be your entire goal as a patient. Am I on the right treatment for me? And even when you don't think you are, ask your doc, and you might be. They might say, you know what, I still think this is the one is the right one for you. However, if your disease is acting out and you have a relapse or something worsens, at that stage, you've got to consider that what you're on is not managing this the way we need it to. And the consideration of switching should be high.
Thank you for that answer. So we have a lot of questions, and I'm going to ask going forward that we shorten up the answers a little bit. I know that one was a loaded question, and it required a lot for you to say. But going forward, you know, we do have a second speaker later on, and we want to get to her as well. So before everybody goes to sleep. All right. So
Sure.
The next one is a very good question, and a person wrote in, there are several DMTs that are for active SPMS. If someone, though, has inactive SPMS, can they still try a new DMT?
Great question. So the FDA recently added a new nomenclature called active multiple sclerosis, and someone's asking, what if it's not active? Well, that's at the discretion of the clinician. If you feel like you're worsening, you probably have active SPMS. So the short answer is everyone technically has active SPMS because the brain is constantly atrophying.
Great, thank you. All right, so before I ask you the next question, there were a lot of people that came in after I had done the beginning announcements, and I want to let everybody know that I am Stuart Schlossman, MS patient and president of MS Views and News. This is an MS Views and News educational program, and of course we do have Dr. Rany Aburashed here, and I hopefully that you heard all that he spoke about earlier, but if not, you will know that this will be put onto our YouTube channel in about 2 weeks. So you'll get notification of that at that time as well. All right, so the next question is, what is the status of any new medications to anything that can help with remyelination?
Yeah, so remyelination is the rebuilding of damaged fibers. And this is really what everybody wants. Can I improve? Can I get better? How do I get better? So currently there are several potential molecules that are working towards this end, okay? I can't say a ton about them because they are early in phase 2. However, we are involved in one of the phase 2 trials and another one starting. And you know, these are different mechanisms that are aimed at, and these are add-on therapies. So you would stay on your MS treatment, disease-modifying treatment, but these are therapies that would be added on to that in the hopes that it could start to rebuild myelin. And a lot of these are targeting a cell called an oligodendrocyte, which are the cells that actually build myelin in the central nervous system.
mute again. Thank you very much. All right, next one. Why is HSCT not considered an option when your neurologist asks you to choose a DMD to try?
Yeah, it's a great question. So HSCT is hematopoietic stem cell transplant is what they're referring to there. And there is a lot of evidence that stem cell transplantation may be a profoundly effective treatment for multiple sclerosis. It is a very rigorous treatment though. And there's a lot of safety concerns surrounding it that have yet to be fully vetted, but we are getting way closer and way better at understanding that. At one point in time, the mortality of HSCT was over 1%, and that's just not acceptable. You can't put someone on a drug where 1 out of 100 is dying. And so it really becomes a safety issue more than an efficacy issue. And the hope as we get better protocols, and they are getting extraordinarily sophisticated and good, is that that will be an option long-term for patients.
Great, thank you for that. Okay, next we have a person wants to know to please discuss primary progressive. I don't know if you hit on it earlier. I'm sorry if you did. But if you can describe primary progressive, and to add that into another question, person wants to know if relapse remitting MS can lead to primary progressive.
Okay, so primary progressive multiple sclerosis typically is, in one way, it's almost viewed as an entirely different disease than kind of our classic relapsing MS patient, okay? Because really what happens is you develop this symptom, and the most common one that I've seen in my experience is a leg starts to get heavy or weak. So usually it's, I began tripping, and then over the course of a year or 2 years, I started to lose that leg entirely, and then it just progressed into the other leg, and it just got worse. So it's kind of this constant barrage of slow worsening, but it's not really slow. It's actually pretty quick. It's over a number of years. And that's obviously very different than someone who has a weakness of a leg from an attack that comes back in its entirety, right? That would be the relapsing MS patient, where they have the attack, they get weak, and it gets better. So primary progressive disease is almost its own entity, which makes it such a challenge to treat. And that's why we only have one treatment at this stage, essentially, for primary progressive multiple sclerosis that's approved by the FDA, and that's Ocrevus, one of the infusions. So the second part of that question, can relapsing MS become primary progressive? Well, by nature, it would not be primary progressive because the primary is the relapse, right? So you started out as relapsing. Now you can become relapsing and rapidly go on to secondary progressive MS, and it's just your timeline is much shorter than most patients.
Okay, thank you. All right, next question. Jill called in that she wants to know, what is the end goal of your biomarker research?
So the end goal of our research, of what I'm looking at right now, is can we find a day where I can see you as a patient and make a diagnosis of multiple sclerosis the way I do now, using your MRI and using your history. Then can I draw blood on you and measure a number of proteins and be able to put you on the exact right drug that you need on an individual level at the earliest time possible. So can I foreshadow your MS before the rest of the world can? So my goal is to emphasize the decision threshold of treatment, because the disease is we call it a heterogeneous disease, which means every single case is different, right? So you're trying to figure out what every fingerprint is. So the biomarker goal is to make it so that we have the best fingerprint analyzers in the world. That's what we want.
Great, thank you for that. All right, I have another PPMS question for you. I'm going to get to that in a second. I do want to let everybody know here that after this Q&A with Dr. Aburashed, that we are going to get Mindy Eisenberg on the line, and Mindy will be, that'll be in about 20 more minutes from now, and she will be doing yoga with you all, okay? Beginning yoga and yoga for people with MS. And I didn't get to announce all that at the beginning, so I wanted to let you know that as well. All right, now go back to this PPMS thing. All right, so Lene, I know I'm not saying the name correctly, but she writes, so with PPMS, I know people who have said the medicine isn't working for them at all, which, you know, could make sense if their disease is still progressing. But if they don't get any benefit from it, why are they still being told to stay on this medication? Wouldn't that be like a waste for them?
Yeah, so it's a great question. So this speaks to the fact that, again, this is not binary. So when we talk about things, as human beings, we like to explain things as A, B, and C, because that fits our brains very well. Someone has A, someone has B, someone has C. You can have a patient diagnosed with primary progressive MS who sees a different neurologist who disagrees with that diagnosis, who doesn't think it's primary progressive MS, who thinks maybe it was a very severe relapse that didn't have complete recovery, and that's all, right? So when you think of this, think of a continuum of the disease. Just because we describe these things, in a binary sense, does not make them binary. So, always consider the fact that there are multiple factors occurring, overlapped, and some of you might have, for example, some of you might have, a lot of shrinkage of the brain, and that's driving your disability. Some of you might have a lot of inflammation on the brain, and that's driving your your disability. Some of you have a combination of both. So when you think of that, that's why in a lot of cases we will treat people, even though technically it might not fit, whatever that binary category is.
Great, thank you. All right, next, Lisa writes, I don't know what to do. I live alone and my MS is not monitored, sorry. I went from every therapist and excellent MS care to nothing. I have 20 lesions on my frontal lobe, at last count. I need help. I'm alone and I have no MS help or care for 8 years. What can she do?
Yeah, so first off, I'm very sorry to hear that, and that's not acceptable, and we have to remedy that right away. So there are several options that you can take here, and I don't know what part of the country you're in, and so I can't answer that directly. The first step that I would do is to go on the National MS Society's website and go to your state's chapter. So wherever you are, I would find the chapter in your state, and you will find a list of comprehensive MS centers that are available to you in that state, or you can at least assess how close they are to you. So that would be the first step. The second step is to find clinicians that do telehealth consultations. So we do this where we see patients from all over the country by telehealth. And then you establish care, and we find a way to get you tested wherever you live, find a way to get you treatment wherever you live, and so on and so forth. It is very doable. And as a matter of fact, if you tell Stu where you live, he might have somebody who he knows in that area, because he does these all over the country and works with different MS specialists. So it all depends on the state that you're in. If you email Stu and let me know what state you're in, I probably can help you get to someone good.
Oh my gosh, and where are you gonna find time in your day for that?
God knows, but it's a quick email.
Right. Thank you. All right, great. Thanks for that answer. Karen writes, I'm not going to say her name, her age. She put in her age. She's been on Ocrevus. She's due for an infusion in January. She's very concerned, obviously, with COVID. She wants to know if she should wait for a vaccine or she should switch to a different medication like Mayzent, transition, and then go back on Ocrevus after a vaccine becomes available. What do you suggest for people to wait for the vaccine or do their medications, or what?
So the first thing I would say is take a deep breath and don't make any dramatic decisions when we're dealing with a science that we don't fully understand yet, okay? COVID remains largely an enigma, and we are rapidly learning more and more about it on a day-to-day basis. So the first step is a lot of assumptions are made that may not be accurate. And so as clinicians, we have to understand we don't know all the answers. And for that reason, you have some respect for that. The first step that I would do is contact your neurologist, okay? Whoever's taking care of you, because different neurologists are approaching the vaccine in a different way. So we don't have a uniform vaccine guidance plan just yet. And to be honest with you, we have not seen the data on the vaccines yet. All we've seen is what you've seen, the press release that says that 95% of, what does that mean? We don't even know what that means yet. So I don't want to get superfluous and make these dramatic changes for no reason yet. The second part is switching medications just because is not without risk. So when you transition drugs, it needs to be done very thoughtfully, and there's a period of time, depending on your MS, that you might have some risk involved. There's something called rebound MS, rebound effects, so on and so forth. So my response to Karen, and then in terms of Ocrevus specifically, we do have some strong data on Ocrevus and COVID at this stage. Genentech has published, their experience to date, and in that experience, there are a small percentage of patients who are at elevated risk, but many patients have done fantastic, even with COVID and being on treatment. So there are a lot of factors involved: your age, your comorbidities, so on and so forth.
Okay, great. Thank you for that. Before we go on to more questions, and we're going to get into a few COVID questions in a moment, but I want to let you know what a patient has written about you, and she wants me to say, please thank Dr. Rany for being so very thorough with explaining and answering questions. She really appreciates that. So thank you, Coy, for bringing that up, and thank you again, Dr. Rany. So now let's go to the next thing, okay? So let's go to a few COVID questions, and then we'll get back into some symptom questions. And again, I'm sorry that we can't ask and answer everything, but if Dr. Rany approves, I'll send him whatever we cannot get to. I'll have him give the answers on it, and then I'll send it out to everybody that's been on this program tonight. Okay? Okay, great.
Sure.
All right. Are there any DMTs with possible certain ingredients that can give you some added protection against COVID? Again, this is probably something that may not be able to be answered right now.
Yeah, so the short answer is I don't know. The long answer is yes, there have been people looking at DMTs as potentially protective in some cases of COVID. And so, again, very dynamic understanding of this virus in real time. So the absolute answer is we don't know. But yeah, you're onto something there. There's no question that there's many people who believe there are certain drugs that may help it. Because remember, a lot of COVID's problem is actually the inflammation that occurs on the lungs. So it's the immune system trying to salvage everything. So in theory, if you're on a certain drug and it dampens the immune system, might that help it in some cases? That's a theory, at least, that some people have.
Okay, thank you. So another person writes, they want to know if we know if there's going to be any side effects from the vaccine for people with MS.
Yeah, it's a great question. And again, I get asked it every day. So the vaccine, understand something. We as clinicians have yet to see the data on the vaccines. We're expecting that December 10th. So we need to see the studies. We need to see exactly what they saw. I know that AstraZeneca's vaccine did have a case of transverse myelitis, and so on and so forth. So these are things that we have to scrutinize in real time. So we will know a lot more, my hunch is, over the next 2 weeks.
Great, thank you. Yeah, so a lot of people, I think, are waiting for the December 10th date, but will they be letting us know specifically? We've heard that it's a synthetic origin and really not a live or a dead vaccine, and how will that affect the MS patient? We've always been told to take something that's dead. Now what do we do on something synthetic?
Yeah, it's not just synthetic, it's a totally new mechanism of vaccination. So you're talking about messenger RNA change. So again, I wish I could tell you I had the right answer to this, Stu, and I don't. And it's frustrating for patients, and I get it. So what I will say is this: the vaccine is not going to suddenly be available to everyone. So this vaccine, we will get data on the 10th. We expect the CDC to review it over the next 4 to 5 days, potentially get an approval at some point in mid-December. There will be a 2 to 3 month period where it's only accessible to healthcare providers, long-term care facilities, first responders, and so on and so forth. So we will have the luxury of several months of real-world data that I think is going to help us guide our MS patients. And as we get into February, March, and the vaccine becomes more available around the country, the hope is that we will have some of these questions answered, and that with the help of some of the big pharma companies who make these MS medications, that they will be looking and scrutinizing what effects it may have on cell A, cell B, and so on and so forth.
Right, thank you. Now, a lot of doctors, including yourself, you throw around the acronym or the letters RNA. Can you explain RNA to people?
Yeah, so RNA, so your DNA and RNA. So DNA is double-stranded nucleic acid, and RNA is single-stranded nucleic acid. So basically, it's what makes up part of your genes. And so with the vaccine, what they've essentially done is used some of the genetic makeup of the vaccine, really an analog of the genetic makeup, given just the right amount of it to trigger the immune system to recognize it and develop antibodies to it. And in that case, develop a robust response should you get infected with the virus. So it's kind of like tricking the body into thinking you have a little bit of COVID, just enough to get you fighting it.
Is that why they're telling people now also that the side effects could be very strong as far as flu-like symptoms? And a person writes that question as well. How will these flu-like symptoms stop before it gets to the breathing problem, or is it everything else?
Yeah, so I think I love these questions because I have the same questions, and I don't have the answer for you. Again, we have not seen, it's not like we have gotten the data from Pfizer or from Moderna before you. We're all waiting for that December. We have to review the study to see what it actually means.
That's right. That's right. Okay, so switching back again, let's go to some symptoms, all right? And then we have about another 10 minutes before we're going to have Mindy on here. First one is, can you tell us more about the MS hug and what can be done for this?
Yeah, so MS hug, or what the patient's referring to there, is really a pain or a pressure-like sensation that occurs around the trunk or the abdomen, okay? And a lot of MS patients feel like something is squeezing them, coming around and squeezing them. And it's most commonly caused by a lesion in the spinal cord, somewhere in the spinal canal. And it can be very irritative, at times very severe, and so on and so forth, and it can be painful. We commonly can treat it with a medication called Neurontin, which is a GABAergic drug, a drug that targets the inhibition of the pain fibers within the spinal cord. And in some cases that works, and others we have to be a little more aggressive.
Thank you for that. All right, next, how do I deal with severe migraines? Now, I'm going to say somebody else wrote that, but I live this, all right? And yeah, the migraines have been so severe lately that I don't know what's causing it to be as severe as they are when I have less stress in my life these days.
Sure. So let's talk about that. So first of all, a migraine in and of itself is a headache that is characterized as a throbbing headache, typically on one side of the head or the other, so a unilateral throbbing headache. And there's associated photo and phonophobia, meaning light bothers you a little bit or irritates it, and noise bothers you or irritates it. And then you may or may not have some nausea, and in bad cases, some vomiting as well, okay? So that is kind of the headache that we commonly see in migraines. That is to be differentiated from tension headaches, headaches that emerge from tightness of the muscles in the neck, where Mindy can get rid of these for you without an issue. Tightness in the neck and back in the back of the head, where you're really, and that's the most common type of headache that we see in the States at least, okay? So a lot of MS patients have migraines at the same time. So treating migraines is a science and an art. There's a lot of different treatments that we have, and we've gotten much better at it over the last couple of years now. So there is a class of medications called CGRP antagonists. These are injections that you take either monthly or every 3 months, and those have had a profound effect at minimizing migraines. However, if you don't have migraine, if the diagnosis isn't right, they might not work. So if you have a tension headache, the treatment's completely separate and completely different. In severe cases, we can do Botox chemodenervation, where we give Botox at certain areas in the brain. But if you're having migraines, migraines are treatable. They really are treatable. Stress can trigger a migraine if you're a migraine patient. And so Stu's carrying too much stress because my webcam didn't work all day, and so he was going to get a migraine if we kept it up.
So what about migraines that lead to vertigo, or vertigo that leads to migraines?
So you can have something called vertebral.
Yes.
You can have something called vertebro-basilar migraine. So migraines. So what a migraine is really the blood vessels are constricting and relaxing, Okay. So you have a period of vasodilation and vasoconstriction that goes back and forth. That's that throbbing pain, because outside of the blood vessels you've got pain fibers that are feeling that stretching. You understand? So if the blood vessel that's being involved is in the back part of the brain, the area that controls balance and vertigo and so on and so forth, you might sense some vertigo with the migraine as well. So that's really a byproduct of what part of your blood vessel is being affected. Some people get ocular migraines where it's behind the eye, and so on and so forth.
Right. All right. So next one is there physical therapy for patients covered by insurance? I don't know if you know that answer, so.
Yeah, I mean, most insurances will cover some degree of physical therapy. Many of them limit it to 6 weeks or a certain number of sessions, and you got to pay out of pocket thereafter. And so, for the most part, you should have access to physical therapy if you have insurance. But it varies from every insurance and every plan.
Okay, thank you. Lisa wants me to tell you right now, she wishes she had a doctor like you. You are an angel, and your patience is blessed. Or your patients are blessed. Well, I don't know if she's saying you have patience or your patients are blessed. So,
Well, I'm blessed to have great patients. How's that? Remember one thing about this, guys. We're working for you, not vice versa.
That's right. Now I have another kudos for you, but I'll read that to you after I do some more questions. All right.
Sure.
So, trying to merge a few of them together. What do you say about diets and exercise to do with your MS? Not yours, but theirs.
Yeah. So there isn't a documented MS diet per se. So I'll start with that. We don't have a diet that every doctor in the country agrees upon and says this is what you should use. We do know that foods that are low inflammatory foods typically help. And so avoiding high fructose corn syrup, avoiding high sugar content food, avoiding white breads and white pastas, and eating really lean proteins and vegetables, really basically like a Mediterranean type diet, typically will diminish inflammation a little bit. And that's always good in an MS patient. So from my standpoint, the ideal diet for me is I want you to wake up, have a couple eggs and some vegetables with no toast, with no cereal. And then for lunch, I want you to have a salad with chicken on it without croutons and 3,000 calories of dressing. And for dinner, I want you to have a lean meat, maybe some brown rice or some beans to give you some protein, some carbohydrates, and some vegetables. And I don't want you having ice cream and Hershey's chocolate bar or chips at night.
Okay, great. Thank you for that. So Mindy is going to be coming on in 5 minutes. So just want to let people know. All right. Next question is balance issues. Okay. Do you recommend anything in particular?
Yeah, so balance is tricky, and it depends what's causing it. So the first step in figuring out balance is why do you have imbalance? So you can have nerve damage in the feet, and that can cause something called sensory ataxia or imbalance because you're not getting your body input. You can have balance issues from a lesion in the back part of the brain called the cerebellum, which controls balance. And you can have balance issues because of weakness of one leg or the other, amongst a variety of other causes. So the first step is to figure out why you're off balance and what's causing it. There is balance training that we do with physical therapy that a lot of times will help and will benefit patients substantially. And it's really just a matter of figuring out exactly why you have it and then coming up with a treatment approach to get it under control, or at least stabilize as much as we can.
Okay, thank you for that. Stretching for spasticity, stretching for leg cramps in the feet, heel pain, walking difficulties. What can you say about any of this and altogether?
So I'm going to actually use this to segue into kind of what I think is probably the most important and underrated treatment in MS, and that is exercise and maintenance of body. Okay, I cannot stress to you the degree to which you may do better if you have an active exercise and stretching regimen. And what that means is it is a part of your life. It is a part of your daily process. I'm not telling you have to be a triathlete. But what I'm saying is that those patients who exercise and who push the body more, the human body is remarkable, and it will try to repair, and it will try to improve, and it will try to protect itself at all times. And even when it makes mistakes like autoimmune diseases. So the more you exercise, the more input you're giving your brain, the more input you're giving your spinal cord, and the better off you're going to be long term. So stretching is a big yes for me, as is exercise.
Great, thank you. 3 more questions, and then the kudos from 3 different people, okay? And then we should be good, all right? So and then Mindy will come on. All right. So cognitive, what can a person do to strengthen their cognitive abilities?
Yeah, cognition in terms of improvement is always a challenge for us as neurologists. It's one of the most frustrating parts of my job, to be honest with you, because it breaks your heart. And so what I would say is there are several factors that we know can at least stabilize and potentially get you working at your best level, whatever that is today in 2020. So number 1 is social engagement. So you need to be socially engaged, talking to people, interacting with people. Isolation will worsen cognition pretty significantly over time, okay? Number 2 is management of your mood. So depression and anxiety will have a profound effect in some patients on their cognition. So we have something called pseudo-dementia that is kind of a byproduct of a mood disorder. So making sure that you are in the right spirits and getting the help you need in that regard. Number 3 is exercise and making sure that you are giving your body those endorphins, giving your brain that feedback. And then the 4th one that I think is very important and very easily solved is making the brain challenge itself. So try to learn something new every day. One of the things that you might consider is maybe picking up one of those Rosetta Stones and learning a new language. I don't care how good you get at speaking Italian. I just want you to be pushing your brain into new areas, and you will see the brain, the brain remarkably will try to expand itself. And we see that with intermittent fasting. There's some studies that suggest that as well. So the brain, can improve itself, or at least stabilize itself. So that's the approach I would take, Stu.
Okay, great. All right, next. Tell us what you think about CBD or medical marijuana.
So in the end, in terms of medical marijuana, the long story short is that it's something to consider if you have spasticity, if you have trouble sleeping, if you have muscle pain. It might be worth a shot.
Okay, thank you. The other one that I wanted to ask you before we switch over to the thanks that people gave, and again, I cannot ask any more questions because we're out of time with Dr. Aburashed, and we do need to get started with Mindy. But the other question that's been looming here is about Botox. Is there anything that you could tell us of how Botox benefits an MS patient?
So oftentimes we'll use Botox for patients who have bad spasticity. So if an arm is very tight, for example, Botox works at basically taking away the input from the nerve to the muscle. And so it relaxes a muscle that's very tight. So it absolutely works in a variety of neurologic conditions, and MS is no different. So if your doctor recommends Botox for significant spasticity, it's worth giving it a shot.
Great. Now, Robert wants me to tell you, thank you, Dr. Rany. I love the way you explain MS. I heard you speak many times, and each time you speak and you say it or you explain it a little bit differently, and each time it's quite beneficial. So Robert wants to thank you for that. And also, Mandy says that she's one of your patients, and she's glad because she wouldn't be able to live anywhere else because you won't follow her there. Now, she didn't say it like that, but I'm explaining what she was referring to, okay? All right. So anyway, so that's that. I'm not going to ask you any more questions. We do need to move things along. But I do want to thank you for being here. I know it took up a bit of your time tonight, and I know it's very valuable, but it's valuable for the 100 plus that were on this call tonight. And that's great because I'm sure many benefited from what you just did. And again, for those that didn't see it all, and for those that unfortunately were not on the call tonight, it will be on our YouTube channel within the next 2 weeks, okay? Doctor?
Thank you for having me. Mandy and Rob, the check's in the mail. Mindy, have fun. Take care, guys.
Thank you.